Ladies, my fellow mommies, we are always so busy, on the go, kids screaming in the back seat, sleeping babies. I have the ultimate hack for you.
Welcome to the Stay Fit Mom Podcast with Krista and Tracy, your go-to girls for health, fitness, and keeping it real in mom life.
If you can't seem to get in a good groove with your nutrition and exercise program, this is for you.
We've coached thousands of women using macros for over 8 years, and I'm well known around here for my 5-day meal prep videos.
What does a macro balanced meal look like?
Hit subscribe to the Stay Fit Mom Podcast and join us for a fun, meaningful journey toward a healthier, happier you.
You got this, Mom.
Welcome to episode 2 of season 3 of the Stay Fit Mom podcast. And just a reminder, we are kicking off this season with the theme, Honoring Your Health with Hope and Action. And today I have the privilege of interviewing Dr. Jake Kelly. His resume is extensive. I'm going to let him introduce himself and talk about his experience in the medical community. But we're so excited to have you here, Jake.
Thank you. I'm very excited to be here today. I look forward to this conversation all weekend. We'll start off with something fun just before I introduce myself. I may be a little energetically, what's the word, volatile as I'm preparing for my first colonoscopy tomorrow. So another screening plan for everyone out there is get your colonoscopy, age appropriate cancer screening. So I'm Jake Kelly, also go by Jacob Kelly. I grew up in Bedford, Texas, Dallas Fort Worth. So I'm a Texan. I went to Texas Tech University for undergrad, had a great time. I was going to go to law school, but I had a life-threatening bicycle accident that redirected me to medicine, which is really my real passion, where I should have directed myself. And I went to University of Colorado for medical school. And then I went back to my roots in Dallas and trained at Parkland Hospital, famous hospital, amazing training, some of the best memories of my life, besides meeting my wife there. Was a chief resident on faculty there. And that led me to go to Duke University, where I completed multiple fellowships in cardiology, research fellowship at the Duke Clinical Research Institute with a master's degree in research, and then another fellowship in advanced heart failure and cardiac transplantation before coming to Alaska, where I've been here for 8.5 years now, where I focus on a full breadth of cardiology from prevention all the way to advanced heart failure and end stage life cardiovascular care.
Wow. How did we get to stumble upon Dr. Jake? And so I want to tell our listeners a little bit about that story. I have a really good friend that I do a lot of life with here in Niceville, Florida. And she is part of my church life group, and her husband connected us as they know very much the ins and outs of what our business is here at Stay Fit Mom and what we strive to do in terms of preventative medicine and weight loss in general, and just all the ways that we're really trying to change family trees, how we can make people healthier long term. Krista and I will come on and we will tell stories from experience. We will tell stories from an extensive experience at that. We've been doing this for 10 years now. It's been a gift, but we don't have the medical experience and knowledge that Dr. Jake does. And so it's a privilege to have somebody on. We can talk about tough topics with a doctor. And one of my favorite things about you, Dr. Jake, is that I feel like you were very articulate and easy to understand. And so that's what we're hoping to bring forth out of this conversation is easy to understand medical topics that we're all interested in and what meat and potatoes our listeners can get from this. So thank you again, Jake.
It's very excited to be here. And I think diving into these topics will be great. And honestly, this is what I do in my clinic. And I really enjoy taking care of patients, and the one-on-one interaction is where I thrive. So this one-on-one is great.
So you summed up all of your medical experience and your schooling, but then also how you got into cardiology specifically. Is there anything you want to add in terms of your own personal journey with health and fitness? Anything else in terms of why cardiology is where you ended up?
I think that's a great question. I loved how you mentioned family trees. Let's change family trees. Let's grow those roots. So my roots, Bedford, Texas. I grew up in athletic family, more Texas sports, except for soccer, which seemed to always be my real passion because I think there was a lot of movement there. I played middle school and high school sports, track, football, cross country, and I was a good soccer player. So I really found my passion for movement through those sports, soccer in particular. And then I went to college and I gained the freshman 30 and I just revolted the exercise. I went and played racquetball a few times at the cool gym at Texas Tech, but at the end of the year, I just realized that first I couldn't get a date, and second of all, I just didn't like the way how I felt. It was about feeling for me, and I transitioned home. And I was taking some summer classes to get ahead in physics and writing, and I just had always wanted to be a triathlete. And I was like, I still don't know how to swim, but I can start bicycling. So I started bicycling in the heat of the day, 20 miles. That seemed to be a target. Initially, it'd take an hour and 20 minutes. And by the end of the summer, it was an hour. And then at night, I would walk with my best friend, Brian Truelove. And we started walking on Harwood Junior High track, and we did a mile. We did 4 laps. And by the end of the summer, I was running 2 miles. It just started by we'd run one lap at the end of the mile, and then we just said, how long do you want to go? And it was dark. It was like 8 p.m., 9 p.m. because it was so hot. And I'd already sweated earlier in the day riding my bike. And by the end of the summer, I had lost 30 pounds. And during that time, that's when I actually first started reading about macronutrients, and I learned about reading labels. And these are things I didn't learn in high school. I wasn't learning them in college as a biology chemistry major yet. So I think that route led to my passion for fitness, for moving, for just living life. And it was really about how I felt. It wasn't about running faster. It wasn't about bicycling faster. Those are fun. And I just liked the way that I felt. And then through college, you do the ups and downs. You're studying for finals. You maybe party a little bit, although I wasn't a big partier. And then I would always find myself getting back on the wagon, just creating these daily habits. And that's really where my journey happened and my passion. Fast forward, and I don't think we have time for this, but I was going to go to law school and become a patent attorney because I majored in biology and chemistry. And literally a few weeks after I graduated college, I'd just done a big half Ironman, and I got run over by a car, and I had to go to the ER as a multi trauma, and I had multiple surgeries, and I had to go to a rehabilitation hospital, and I had to learn how to walk again. So I couldn't go to law school at Tulane because I had to learn to walk again. I couldn't carry a backpack.
Wow.
And then in that period of time, I decided to go to medicine. And that's where this kind of passion of movement, rehabilitation, and compassion for my patients really came together. And then the rest is history. Now, cardiology in particular, what's really nice is that we take care of very sick patients sometimes, and they immediately can do better when you talk about an acute myocardial infarction. So that's really exciting. And then heart failure in particular, one of my loves is patients can be quite sick. And now with different medications, which really work on hormonal pathways, much like GLP-1s and other things that we're learning physiologically, we can rehabilitate them and get them a little better. And you build these lifelong relationships with patients. And I've really liked that chronic disease management, which is actually much like coaching. And my patients have done better and better. And now with our technology, pharmacotherapy, rehabilitation sciences, exercise. I have patients living 20 years that were living 3 and 4 years. So now my patients
Wow.
are living so long, I had to go back to preventive medicine because now I have to make sure their lipids are doing well, their metabolic profile, talk about their diabetes, because they're going to deal with these other things that all of us are struggling with. So that's my 360 degrees to back now. We're like, why don't I prevent people from getting heart failure? Why don't I prevent people from getting cardiovascular disease? And we need to start earlier, all the way down really into childhood if we can. But for me as an adult physician, I'm really just trying to get the word out and try to push back. And it doesn't mean we can't recreate things in our 40s and get back on our health, but the earlier we start, the better. So I know that's a long 360 degrees, but I think it helps you understand where I'm coming from.
For sure. I think that story of the freshman 30, so many of us can relate to that in that a lot of our clients that we work with, huge athletes in high school, and then you're consuming the calories that you would as a 16-year-old, and all of a sudden you get to college, your movement goes way down, you pack on the pounds, and then you're chasing that feeling like this doesn't feel right. My clothes don't fit. Thank you for sharing all that. It's wild to see how sometimes those traumas in our life really make our life take a dog leg to the right. And oh, I thought I was going to do this. And then this happened to me. And now I'm on this path. And then I had this question, but I think you already answered it. You've moved from treating disease to wanting to prevent it because you've just seen the lasting effects of, wow, these medications are extending the life of our patients. I've heard that too with cancer patients. Cancer patients are now in stage 4 getting these hormonal therapies where now they're living way longer. It's no longer a death sentence, I guess is what I'm saying.
I
So,
think that's exactly right. And I think what you're touching on is you mentioned hormonal therapy again. So I think what we're doing is we focus so much on the outside of the body, and now in a good way, pharmacotherapies and drug companies and science have developed techniques to treat problems that exist. We diagnose cancer, we have therapies to treat that. We diagnose cardiovascular disease, we have treatments or procedures to treat that. But I think what you're getting at, and I really like this from the hormonal therapies, is what is the cellular level foundation? And I think that's where you get to the macronutrients and the food as the foundation. Many of these things that end up manifesting as diabetes and cardiovascular disease, strokes, cancer, we probably can reduce some of that risk, maybe even a lot, if we really focus on the foundation, which are instead of being inactive, being active, instead of just eating because we're hungry and eating processed food, saying, oh, food is medicine. Let's make sure I get the right macronutrients, good protein. Plant protein is great. Animal protein, if it doesn't violate some of your religious personal beliefs or digestive habits, is great, but all the diversity there. Then carbohydrates aren't bad. Let's get the right amount of carbohydrates from the right sources, from natural sources that take a little longer to digest. That's what
Mhm.
processed foods are so bad, is you get a concentrated load of calories without the natural ways for your body to digest the peeling from an apple and the different coarse fibers that you can get from more natural things like couscous and farro and even brown rice, maybe over white rice. Without getting into that, I'm not as much of an expert, except that natural things that take longer to digest are better. And then healthy fats are very important. The United States really made some errors when we went to this fat-free thing in the 1980s, and I think that was a lot of this. I think we'll talk about this later. Advertising, and real foods are good. Fat is good. Protein is good. Carbohydrates are good. It's just the relationship to how many do you need, when do you need them, and how does that support the life that you're trying to live. So if we go back to those roots and the foundation, I think we can reduce all disease states. I
Mm.
unfortunately do not think we can cure all things, but I think we can reduce them. And then if we get these diseases, we'll be in a better physiologic state to conquer them, to fight them, and to live longer with modern medicine.
Over the course of your career, what patterns have you seen in patients' lifestyles that contribute to heart disease and other chronic illnesses? What do you feel like you're seeing most people do? And you touched on this already with processed foods and things like
Mhm.
that, but anything else you want to add?
Yet, I think it's a great question, but you're right. I think processed foods is just a really nice way to mentally put a framework together. So, processed foods is just fast forward America. I need my calories right now, right here, right now. But if we back up and say the things that are leading to these patterns in patients to get to develop chronic diseases, these were not negative or bad people. I've done all of these same things, but we have more sedentary lifestyle. When the
Mhm.
United States chose to make a network of highways that we drove everywhere instead of having railroads and bus systems that we transported and walked from our homes to the bus. We took away a lot of these natural ways to be more active, which we say the Europeans are more active. And that's just their natural way that they get around. You have to walk a block or 5 blocks to go to the bakery to get some food. So, sedentary lifestyle, whatever we can do to combat that, park further away from the grocery store entrance or the parking lot that you're going into, take an extra flight of stairs, just be more active, take a walk after dinner. I'm going to highlight that again later if I have the opportunity. Fight the sedentary lifestyle. The processed foods is another one. Our bodies aren't made to have essentially drugs, right? Directed, targeted sugar, fructose, glucose. The body's supposed to digest it out and soak the marrow out of life there. And if we're avoiding that, we're just going to get straight calories. We're not going to burn up any of the excess calories, and we're going to store it as adipose tissue. And here's a big one. And I'm glad you re-asked this really important question. It's stress, right? How many patients have talked to you and your listeners and me? And I always thought, oh, stress doesn't do anything. Absolutely. Stress is killing us slowly, right? It's affecting our sleep and we neglect our sleep. So I really put stress and sleep together. We need to reduce
Mhm.
stress through mindfulness, through spirituality or religion. As a physician, I try not to dive too much, but I really think that the mental, spiritual, religious aspect of life is so undertreated. And I think that's a big
Mm.
important thing for everyone. And then those things, including physical activity and a better eating style, will lead to better, more restful, recovering sleep. That's really our best medicine is actually sleep. So exercise is medicine. Actually, exercise is the stress that then if you can recover with good sleep and nutrition, you get strong. So
Mm.
exercise is a stress, but it's
Mhm.
the recovery and the nutrition you support that with sleep and nutrition that are really helpful. So if we were
Yeah.
to get better at all of these things, I think we will reduce cardiovascular disease, diabetes, obesity. And that's where these same pieces overlap, and all of us just not feeling as well, all the way to those of us, which many of us, myself included, will manifest with chronic diseases. And we can fight them, we can get them better, but we got to go back to our roots.
I had a client check in just this week, and she's had an extremely high stress work week, and she listed them, but she's like, I didn't even have time to eat. I was so stressed. I didn't have time to eat. And as a coach, it's easy for me on the outside to give her that perspective. When you're eating enough, when you're eating macro balance, you're giving your body a fighting chance at handling higher stress situations. And so you're increasing your margin and capacity for stress when you're eating macro balanced, when you're getting enough sleep, when you're getting your daily exercise. And so for sure, it's this vicious cycle that I feel like people are in. I don't have time to eat. I'm stressed. Oh, and now I can't sleep at night. And now my hormones are all out of whack. And I'm just going to have more coffee, more stimulants. So we can for sure get on this very unhealthy cycle that puts us at risk for disease. So, my next question is, how do you think the medical system could better prioritize prevention rather than treatment?
Man, that is a great question. And I think what you're talking about is where I think we're going, whether the systems and the payers know it, is traditionally medicine 1.0 was just, we see things very late stage. It was more palliative. We had some kind of very basic procedures, and we could help people suffer a little bit less and or maybe make them live longer with some very basic things. Medicine 2.0 is where we're at right now, right? What is that? We're getting really good at diagnosing diseases once they manifest. More, think of stage 2 cancer or late stage 1B cancer. We can diagnose diabetes or the highest risk factors for diabetes, pre-diabetes, and then we can treat them. We get pharmaceutical therapies. We have amazing procedures, and we are busy in medicine. I think there's not enough physicians. There's not enough nurse practitioners and physician assistant associates and nurses and medical assistants. Medicine 2.0 is overwhelmed. But I think what people want, and that eventually might help medicine 2.0, is medicine 3.0, which is this focus on preventing disease, delaying disease, improving the baseline foundational health structure of individual people, so that when you do encounter a medicine 2.0 real problem, hopefully it's early cancer, hopefully it's early cardiovascular disease or a small heart attack, and we can treat it and get you back on the right track, pushing you back to being very healthy. But we have time constraints. We have a reactive culture of diagnosis to treatment. There's financial incentives more for procedures or more expensive things over prevention. And that's not on the individual physician typically, meaning like I don't get paid to prescribe a particular drug. I think that the cost for a visit with me, if you're more complex or have more diseases or more time a little bit, I'll get remunerated a little bit better. But it's really the bigger imaging studies and procedures. So we want to find things that we can then do, and we do a really good job of that. So to shift it back to change the reimbursement, I think probably needs to incorporate things like long-term management, coaching, paying for performance, but those get really in the weeds. And you have hospital administrators that are managing these very complex accounting books that are very important and trying to keep everyone moving through the system and treating them. So it's hard once you go through a system. I think individually as patients, we need to just push our physician and our clinicians to spend a little bit more time with us and focus on more prevention things while still doing medicine 2.0 in the interim. It's just hard. We need to write our congressmen and women to say we want to focus on prevention. We want to prevent disease, and we just have to do it as a movement of the people, because the docs and nurses and medical assistants, they're doing the best they can. But I think stepping back and trying to just say, hey, I think you're doing great. I know you're so busy. If you get time, or can you do some education or share this? There's ways that we can engage our doc, even though they may have 6 or 15 minutes with you. But I think being compassionate both ways is helpful. And we just as a society need to say, we want more prevention. We want more health focused rather than disease focused. But I think it's hard.
Yeah, for sure. There's a lot of complexities there. And I'm glad that you listed those out, because those are things that as a patient, as a relatively healthy person, I don't see those kind of complexities. I don't know what the statistics are, but I mentioned this in the podcast episode I did with Krista. What percentage of the population, there's like a phrase for it. I want to say 1% of the population is using 95% of the expenses when it comes to healthcare and doctors. Am I
Yeah,
on a path
no,
here that
you
you're
yeah,
okay?
I think I think there's a statistical principle, but it's basically the 80-20 rule. I've heard cited many times in medicine. I cannot tell you the exact resource, but essentially 20% of the patients are using 80% of the resources. You
Yes.
can call that doctor's time, you can call that a nurse's time, you can call that total dollars
Hmm.
essentially. And then of that 20%, there's I think you're right, 1% that's probably using the majority of that 80 of that 20% is
Hmm.
80%, however you want to
Hmm.
do it. Yes, it's a very small number of folks that need a whole lot to care for them. And honestly, that's been amazing for the United States in particular. We've helped push medicine forward and develop some of these amazing therapies because we're willing to do so much for each individual. But now,
Hmm.
as resources get tighter, inflation goes up, it's really hard, and it's hard to know what to cut and what to support because you want to support every single person. And I will say the beauty of medicine is as physicians and nurses, nurse practitioners, PAs, we learn to prioritize our patient one at a time. And I think that's amazing and one of the ethoses and principles I love. But then when you get to the step back population level, how do you pay for it? How do you have enough
Hmm.
time? How do you have enough hospital beds, operating rooms? It's really challenging. And that's where the payers, your congressmen and women, and some of these leaders in medicine need to come together and have honest discussions on how to do things. But it's really hard. Although I do think if we push for more prevention, maybe even a little bit more availability to being able to see docs to discuss these concepts more than once a year wellness visits, I think you'll delay and reduce the time and burden downstream. But it's hard to see when you're dealing with accounting principles that you're trying to just make
Sure.
ends meet year to year.
Sure. Yeah, that had me thinking of a lot of thoughts. I'm going to hold off on some of those thoughts because I want to get into the peptide movement and weight loss medications. These are all the rage. They've been all the rage for some time. Obviously, this is the world that I live in with weight loss. But I wanted to ask you some basic questions about the peptide movement. I guess I'll start with when we were first introduced as mutual friends, that friend told me that your tagline is macros before meds. Can you explain what that means to you?
Yeah, I think it gets to the everything we're talking about right now, which is that root culture. So macros or macronutrients, they really are the medicine that feeds our body, that feeds our cells. And then meds are so important. But really what macros before meds identifies, and I'm going to use a word, I don't know if it exists, culturalizes, is that we need to think about everything we put in our body, be that medicine, be that chemicals on our skin, be that drugs or pharmaceutical therapies with a specific target, are treating our bodies at the cellular level and having an effect, positive, negative, neutral, benign, maybe later. So when you think about that, it helps people go, okay, why am I putting this in my body? And I think you're going to make better food choices or energetic choices. And then it also, I think, is going to help you go, okay, do I need this medicine right now? Is this medicine really going to affect my life in the short term, medium term, long term, and then lifetime effect later? So if you're not thinking about it from beginning to end, I don't think you're ready to take a medicine or not take a medicine. You really need to
Right.
understand, why am I willing to take this medication? And it helps you go, is this going to have a side effect profile, which can be positive weight loss, positive reduction of cardiovascular events? Or is this just because it's going to make me look better or make my scale go lower? So that's why
Mm.
I think macros before meds puts you in the mental framework to be ready to go on a treatment program.
Okay, so let's just jump into as simply and plainly as you can put it. We're seeing an explosion in the popularity of weight loss injections like semaglutide, trizipatide, and I know that there's more coming. Can you explain in simple terms what these medications do in the body?
So GLP-1s, glucagon like peptide 1 agonists, they essentially mimic gut hormones. And what are hormones? Hormones are chemical compounds that are produced in our body, peptides, and they allow one organ system to talk to another. What's an organ system? The small intestines, the stomach, the large intestines, the brain, the heart, the kidney, the liver, and it could be even on the micro scale of different portions of the organs or organelles, smaller components of organs. So fancy words, hormones, they communicate between different organs. The specific GLP-1s and these new related peptides or other hormones, they slow gastric emptying. That's going to curb your appetite. You're not going to be as hungry. Ultimately, it's going to improve insulin sensitivity, and you ultimately feel fuller and don't eat as much, and you gradually lose weight. So most of these downstream side effects, weight loss, insulin sensitivity, hemoglobin A1Cs come down, glucoses are better, probably have energy balances, glucose levels getting better, less inflammatory stresses around the body in terms of these like interleukins and things like that, other kind of hormones and chemicals our body's using to communicate. You're down regulating all the stress, you're letting the body communicate more easily, and you'll lose weight. And then that can give you other kind of positive feedbacks. Now if you're getting into some neural feedback about how you feel about yourself, how you feel, right? Get back to that, why did I really want to lose weight? And even now, if you feel full or if you feel uncomfortable, you don't feel great. If these medicines allow you to feel more comfortable in your jeans or your pants, you're going to feel better. And then you're going to feel better later. So they work by mimicking natural gut hormones, and we just feel fuller sooner, getting us back really to our roots.
I heard the comparison, something to the effect of GLP-1s mimic what bariatric surgery would do, but in a far less invasive way. What do you think about that comparison?
Yep, I think it's exactly right. And now with these newer agents, so you have the first line therapies, which is just glucagon like peptide 1, and then we're adding on gastrointestinal peptide that's going from semaglutide or Wegovy to tirzepatide or Mounjaro. And now you have this retatrutide, which is going to add on glucagon. These multiple peptides here are hitting multiple different hormonal aspects of digestion, leading us to feel full and give those signals back to our brain so we don't eat as much. And they're simulating a lot of what bariatric surgery, the various types, I'm not going to get into, nor would I be able to explain all of them. The traditional one being the Roux-en-Y bypass. But essentially, with bariatric surgery, you give a mechanical advantage that you can't fit as much food through the passageways, and you actually then lead to these appropriate hormonal feedbacks that gives the body a fuller sensation. Yeah, and now with these double and triple receptor agonists, or just think newer medicines with more therapies, we're pushing weight losses to 25% to maybe even 34, 35%. That'll rival bariatric surgery. Again, the nice thing about a surgical approach is maybe you only have to do something one time, although, right, there's side effects based on surgeries and redos, whereas medical therapy, you could turn on or off potentially.
Okay. And you touched on this a little bit, and I hope that I'm understanding this right. The birth of semaglutide is an accident, but now that they know that this is having such a great effect on people in terms of weight loss, now all of their research is focused on this. And so these other peptides like tirzepatide and the like are more hyper focused on those hormone interactions.
Yeah, so when you think about it, so if you get, there's natural ways to increase your GLP-1s, right? If you have a very high fiber diet, you're going to feed your microbiota, the bacteria in your gut that produce a lot of these hormones, and they're going to be able to produce a higher concentration. You're probably also filling up your gut with these indigestible or partially digestible, soluble and insoluble fiber, and that will slow gut emptying and give you these kind of feedbacks to your brain that you're fuller, and then you eat fewer calories. So that's why it's good to eat less processed food. It takes more time. It lets our body go, oh wait, I have had enough calories, I'm full now. So what these hormones do, glucagon like peptide 1, so main peptide compound drug we're using now, semaglutide is the generic name, and then the trade names will be Wegovy. And then for weight loss and Ozempic, when it was more for diabetes, I'll get some of these back and forth because I try to use the parent original generic name. Tirzepatide is a dual compound, meaning that it is as very similar to semaglutide, the GLP-1, glucagon like peptide 1, but it also has gastrointestinal peptide, another peptide that's going to give feedback to say you're full. So that's one way that our small intestines and large intestines are talking to each other. And these newer agents that are in phase 2 and phase 3 trials, we won't get into that, but phase 2 means it's been shown to potentially to work and to be safe in animal models, and you move it along. And phase 3 is when we're actually investigating studies in people, and there's typically an outcome. And the retatrutide is a triple receptor. So it's a GLP-1, a GIP, gastrointestinal peptide, and it includes glucagon, and it's showing potentially even more weight loss. Now, do we know if these make people live longer? Do we know if they reduce atherosclerotic cardiovascular events like heart attacks and strokes? We do not have that data yet, so those are not available in the FDA pharmaceutical therapy world. I suspect in the peptide world, offline, non-regulated, you may be able to get compounds like this, which I am not promoting. But as we talk about all these things that are becoming available and people say, let's take peptides, peptides are drugs. It's just did they go through the FDA processing, which as a physician, I am a fan. I know there's been conflicting info and things, but it's the best that we have. The European Medicines Association is the European way that different things get approved. So if something's available in Europe, I'll probably tend to trust it as well if it went through the traditional way. But back, all we're working on is natural human physiology, biology. And do we even really need to do these things? If you can eat more fiber, so that's why we go back to macronutrients before meds. If you can eat more fiber, if you can stay fuller naturally, maybe you don't need to go on this journey to medications. Or if you need to use medications, maybe that's just a jump start to get you back and set this foundational work to really use these therapies. So if you understand the physiology instead of just, I'm ready for the pill, I'm 30 pounds overweight, I want to be healthier for my family, very valid, appropriate concerns. But you really should start with this framework of let's get your macronutrients in order, let's get your foundational support, building protein and lean muscle mass to support this weight loss.
Next question I want to ask is, now I'm seeing claims that these peptides are reverse aging people, that they're working on peptides that can increase muscle at the same time as people losing weight. I guess my concern would be if I'm taking medication to produce these hormonal things to happen in my gut, is my body going to forget how to do this naturally, or am I putting myself at more of a disadvantage in years to come if I don't want to take this medication for the rest of my life? And that's the piece that I don't feel like is being answered by the mass population of influencers that are like, this is the best thing ever. I have no food noise. I just want to take this forever. But at the same time, I want my body to do what it's intended to do. And am I putting myself at a disadvantage? So that's the path that I would love to get into with you, Jake.
Yeah, I think that's great. So let's think short term. These drugs are effective for losing weight. They improve glucose control. We're reducing cardiovascular risk, strokes, heart attacks, heart failures, depending on which med, which doses, right? So they are effective. What's the data? 2 to 5 years look pretty good. Long term, we're still studying the durability of these therapies. There is real potential for muscle loss if you don't pair this with appropriate protein intake and strength training. And then there's unclear exit strategies, like you're talking about. Am I going to be on this medication forever? I think if you go back to that framework that connected us, macros before meds, muscle is medicine. If you're thinking about that and setting yourself up from macronutrients with protein intake and then appropriate strength training and physical activity, and you still need that jump start, you're 30, 50, 80, 100 pounds overweight, or then by all means, I think a trial of medical therapy when you're thinking about your exit strategy would be a very reasonable thing between you and your clinician. GLP-1s can buy you time, but you're going to need to use protein and pumping iron to buy life years. I really believe that. You cannot out inject a fork. You can't out compete barbells. You need to be natural too. And that's where you got to go back to the macros before meds. So if I were going to, and when I speak with my patients about these, and many of the patients I'm now using for full blown diabetes, right? And then full blown heart failure, typically both 40% of patients with heart failure have diabetes. So I've prescribed these medications hundreds and hundreds of times. Maybe I'm in the thousands now. I'm unsure because I share them with my primary care docs and we're all just fighting the fight. We're doing medicine 2.0, treating disease and winning, but still a continuous treatment. So great medicines for diabetes. When we're starting to push this back to more preventive space, pre-diabetes or pre-diabetes insulin resistance, I think for me, and again, I'm not on one of these therapies. I would think about it if I was 20 or 30 pounds overweight, but I still would set up the framework. 85% of people that try to come off these medicines will regain much or all of the weight that they've lost if they stop the medications. Of those 15%, those are the folks, again, this is not randomized controlled trial focused. This is more observational post clinical trials. of those 15%, it appears that they have reset their life. They're focusing on very good protein intake, their total energy intake. So we can say that's macros, but it's really how many kilocalories do they need per day? Is it 1800? And they put their body to eat about 1800 plus or minus and get into their body's natural set point. And they are incorporating physical activity with a strong component of resistance training. A lot of people get scared when you hear that. I consider yoga, Pilates, pull exercise, those absolutely are resistance training. I think if your spine and joints can handle it, getting even some light dumbbells, maybe moving into heavier weights are outstanding for most patients, even older patients, but it's really going to be patient joint specific. Sometimes a physical therapist or trainer in coordination with your physician is going to be a better pathway for which physical activities is best. But I think focusing on these aspects will really let people know if the medicine's appropriate in that exit strategy. I feel confident people can exit these drugs, meaning stop them or wean them down to lower doses and potentially off if they've set their foundation right. So I hope that kind of lets people know. If you can avoid the medicine, I would avoid the medications. If you have uncontrolled diabetes, you probably should just get on the medicine and still work on the foundation. But if you have pre-diabetes, insulin resistance, you're overweight, please focus on the lifestyle aspect first for 12 weeks and see where you've made a difference. And then if you need Munjaro or Wegovy to use as a tool to lose that weight a little bit more expeditiously, I think you're going to do really well because you've set the groundwork. Now you're following a plan and you're hopefully thinking about an exit strategy. Okay, this is a 6 month, 1 year journey for me to lose that half a pound or pound per week. And then I'm going to be at a safer weight for my joints and for my, to be frank, reduction in visceral fat, which is going to reduce chronic diseases. That's a wonderful pathway to work
Mhm.
towards. Can we do that as patients? Many of my patients may not have a choice, but I think some of your clients and regular everyday folks that aren't getting this information, that's a framework I think they can work with to go, I don't even need to go see the doc yet. Let's just work with my coach and my trainer, assuming I'm safe, I'm not having chest pain or palpitations or shortness of breath, like work on those foundational issues. Then if you need that tool, by all means, use the tool. I would absolutely consider one of these therapies if I'd done all the groundwork first.
That was such a comprehensive answer. And I guess what I'm taking from that is that it is so individual specific in terms of risks outweighing the benefits, long term, short term, what your goals are. What I've mostly been seeing is just social media. This is the next best thing. But there's also this other piece of there are these really sick people that need these medications, and now there's a big shortage. Anything to say about that? Is that something that we should be considering?
I do think that when I look back somewhere between 2 and 4 years ago, that definitely was the case. That definitely there were people that had somehow got access to these drugs either through cash or through the pharmacy or direct from companies, although I don't think those programs were available. And they were limiting the supply to patients with disease. I do not, in my practice, again, I'm focused in Alaska, but I have hundreds of people on these drugs actively that I share with many other primary care doctors. And it is more of an insurance cost negotiation rather than supply chain at this time. I could see supply chains coming up again, but right now it's not a problem. And honestly, that's what allowed the compounding pharmacies to make these medicines. Whenever medications are in shortage, the FDA, I'm going to misconstrue this somewhat, but there are pathways that compounding pharmacies can make these compounds very similar, biosimilar, but not bioidentical medications. So they're not necessarily as safe because they're not as rigorously studied in that exact form. And that's what a lot of folks were able to get access to. Sometimes my actual patients, sometimes just folks that wanted the benefit of the therapy. So I don't think that's a barrier. I think right now the availability seems to be there. It's really going to be the barriers or costs. But if a patient can focus on themselves and with their clinician, then I think it's fine to take these medicines from that standpoint. You're not taking it from somebody else. It's not organ transplantation where we need to give organs to the sickest patients, the ones that are going to die the soonest. It's really about a personal patient physician precision plan rather than supply demand.
That's great to know. Okay. There's speculation that pharmaceutical companies and even doctors are financially incentivized to prescribe these drugs. Is that true in your experience?
I would say in general, I don't think you need to worry about that as a patient. So pharma markets heavily. And this is my own personal belief and bias. If pharmaceutical companies could not directly advertise to patients, I think much of the influence would be reduced. Now, I also believe in open knowledge and sharing. So that's a complexity. So, folks, now with the advent of the amazing search engines and artificial intelligence, we can find out about these new therapies and different things. But directly advertising to patients in the last 20 plus years has definitely opened things up. I am more likely to get asked about a rare drug than me to present it to the patient because it's just the patients that I need some of these rare drugs that I treat some rare diseases are very uncommon. Certainly, pharma influences me. They want to take you out to lunch. They want to buy you coffee. There are speaker programs. So if you speak for a company at conferences, that you can make a little bit of money. But in general, physicians are not paid to prescribe therapies. There's no kickback. It's actually completely illegal to do that. But the system is definitely influenced. But it's normally influenced on a much higher scale. It's much more influenced on your pharmaceutical, on your health plan. Your health plan is going to negotiate or work with these PBMs, if you've heard that term, United Healthcare, biggest healthcare organization, and they're negotiating to get better rates. Your health plan's negotiating to get better rates, getting on the formulary at your local hospital or your hospital system. Those are the big influences. A handful of physicians, probably in the 1 to 2% range, may be able to make a fair amount of money speaking out around the country about various drugs. The nice thing is this is all available and it's an app. So you can literally type in open payments, Jacob Kelly or Jake Kelly, and you'll be able to find out how much money pharmaceuticals have spent on me. Like every single time I go to coffee, it gets registered as like $3 or $6. And then you can see what the average physician is at in their specialty. So that is readily available data. So if you're ever nervous or worried, if you've seen me or some doctor talking about TV and it says whatever brand name there, if you want to look them up and be like, okay, maybe I want to hear about this from somebody else. But in general, I think we're physicians and medical providers are pretty unbiased on the very local level. Really, if you think about it, I'm more biased and stressed just trying to answer your question so I can get to my next patient without feeling rushed and trying to do the best that I can. I think that's more. I think as a patient, I want more time with my physician any way that I can. So that's what I would just find the right doctor or a PA or nurse practitioner that can help you and spend time with you, then that may be your better strategy rather than worried about this influence. But yes, how do you really influence that? Like write to your congressmen and women that we want available information, but we may not want direct consumer marketing or however you want physicians to be advertised. Now, my understanding was, I think this is 1980s and pre, used to physicians could get flown to a conference for a weekend in Vail and have the entire thing covered. But that's beyond before I even started medical school in the early 2000s. So I think this is 40 years ago now. But things run true. But I'd be honest with you if I got those kind of things. But I can get lunches and coffees paid for whenever I want. I do it relatively seldom because my time is just valuable to me and I want to spend time with my family. I think in general you can have a trust relationship with your doc, nurse practitioner, PA, nurses, MAs. We're influenced, but it's on the lower level.
I think that's going to put a lot of minds at ease. Just knowing that information is out there is very helpful. So you mentioned insurance a little bit in your responses. How does insurance coverage or lack of it affect who gets access to these medications?
Yeah, again, this goes back to our framework of medicine 2.0 to medicine 3.0. If you have a disease, insurance is typically going to cover it. GLP-1s are very good for diabetes. So they're in the guidelines for multiple diabetes societies and cardiovascular societies now. So insurance is inconsistent in its payment, but it favors diabetes way over obesity. It does create disparities. We now have this indication for a reduction in ASCVD. So if you have coronary artery disease or stroke, then you're probably going to get the medication approved. If you don't do it now, it probably will be coming to you. If you have another disease called sleep apnea, Peptide has been approved for that indication. As a physician doing medicine 2.0, I have a lot of tools, right? I diagnose something. But for those of us in this kind of pre-diabetes, weight loss space, it's going to be hard to get coverage. The nice thing is the two main companies right now are having reductions in the prices and through direct access through their companies. So I think that's Novo Nordisk and Eli Lilly. So exploring these new plans is going to be helpful for folks. So you may need to go outside your insurance. You probably can use your FSA or HSA account, but these prices are being pushed downward and they're going to be more available drugs to us. And now with these new compounds coming through, competition reduces price and new therapies. So I think these are going to become much more available to us in the United States. There was some press, I think, from President Trump pushing Europe, and I think Europe's prices are going up, and maybe they theoretically think that helps us. But a lot of people get upset, oh, that doesn't do the XYZ. But the nice thing, these drugs and therapies are real. They have a benefit for all different types of patients, and I think they're going to be becoming more available. Now, as the patient that needs that right now, and it's 500 or 1,000 a month instead of 1,300 a month, that's still really frustrating. That may not be affordable, but it's coming. And yeah, push your insurance, look for what your insurance covers. And I think they'll be coming more online because honestly, they're in the short run, they're cheaper than weight loss surgery. In the long run, though, if you're on this 20, 30 years, then weight loss surgery is probably cheaper when you
Mm,
think about it as an insurer and just pure business. So a lot of
mm.
things, you got to explore your insurance. You got to read some of the details. You got to write your legislators on the state and federal level. And luckily, these companies are listening and they see, honestly, they probably see a profit margin from direct sales to consumers with a physician prescription.
Very briefly recap in terms of indicators. If you have the indicators of diabetes, that's the number one indicator. You're going to basically be a shoe in for insurance coverage, and then it goes down from there. What advice do you have for somebody listening that is considering the medications but might have all these thoughts roaming around in their brains? Where would you start if you're on a consult with a patient? What does that look like for you?
I include this in every one of my clinician notes. I think my partners laughed at me when I came to Alaska 8.5 years, and I'm telling heart failure patients to be more physically active. I would start if I did one thing, and this is a new thing for me in the last year and a half, and I don't do it every night, but I would walk after dinner. Movement after meals lowers your glucose, it improves digestion, and you're building a habit. And I would stack from there. If you only can go 5 minutes to your mailbox and back, great. Build habits. Walk after dinner. What would I do after that? I try to walk after lunch. I have a lot of staff where I work that patients are walking. We have a nice walkway. They go walk outside. So if you're an employer, strongly encourage, maybe even have a reduction in your insurance. It's probably going to reduce your healthcare costs. Give them time and motivation to go walk at lunch. And then the other one is walk in the morning. So if you could do those various things, starting with walking after dinner, that'd be the number one thing that I do. A new thing that I've incorporated, there was a really interesting study that's been pushed through social media, and it looked at comparing four groups of people: sedentary folks that would walk 30 minutes a day, folks that walk 10 by 3 minute walk breaks throughout the day, and then folks that did 10 sets of air squats. So body weight air squats. You could do this at your desk every 45 minutes. So 10 times 100 air squats. And after I believe it was a 12-week study, there was a reduction in hemoglobin A1C in two groups. In the groups that did 10 intermittent air squats 10 times and 10 3 minute walk breaks. The 30-minute walk in the sedentary groups were no different. So it
Wow.
lets you know that sedentary time is a poison for us, and we need to combat that. And even small movements repeatedly throughout the day are going to help. And I think if you start walking after dinner, I think that's going to set your habits, and it's going to help put you on the right mindset so that if you do need to move on to medications, I am just not getting there. I am doing this weekly, I'm doing this daily activity. I'm getting to 7,000 steps. It looks like that may be a number that's more palatable to folks than 10,000. And I'm just not moving the needle. I'm eating healthier. That's when I think about a therapy.
Hmm.
And if I had three simple habits besides this: aim for 100 grams of protein a day, do some sort of strength training 2 to 3 times per week, prioritize 7 to 8 hours of sleep.
Hmm.
Start with small wins, stack these habits, measure your progress with your ideally a coach and a physician, as I think that's real success. You have the knowledge now. Knowledge without action is wasted. Just get moving and you will be successful. And it is okay if you need to use a tool such as a GLP-1, but if you've set the framework, you're going to be successful and you're going to have an exit path to potentially stopping these therapies someday. And that may be 24 weeks, it may be 72 weeks. That's okay. But I think if you set the framework, otherwise you're just taking a pill or really an injection. They have them in pills now, and that's okay. And that's absolutely okay. But if you really want that framework, which I think a lot of your listeners do, the regular person does, we don't want to pay for meds. We don't want to take a pill, but we can use that help. And this is a framework of medicine 3.0. I really, let's just help them before they've had a disease and get them back on track.
Love it. Dr. Jake, this has been so awesome, very inspiring, but also I feel more equipped to make decisions for myself personally. And I hope that all the listeners will also feel that this is so much more ideal than a 5-minute doctor's appointment or a 15-second social media clip. Thank you so much for spending this amount of time, especially when you're sharing with us how precious time is with clients. We really appreciate you coming on here and spending it won't be an hour once I edit it, but I know that this has been an hour of your time and I'm very grateful. Where can people find you and connect with you if they want to learn more about your work?
That'd be great. So I have an emerging website, jakekellymd.com. That'll direct you to my newsletter. I'm writing on Substack once or twice a week, really focused on cardiometabolic health, VO2 max, just staying active, tidbits, sharing a little bit about my life and journey, because I think when you see we're all dealing with the same struggles, it's helpful. And then on Instagram and X, it's my handle's at jakekellymd. Love the follow, would love a question. Happy to help. If I know docs all over the country. If you have a particular area you want me to try to find one for you, I'd love to do that. I love helping people. I think my other final thoughts is that prevention really isn't boring. It's freedom. Build fitness and nutrition now, so meds and hospital stays are delayed in the background of your life. And if you do need them, you're going to do so much better. Thanks for having me, Tracy. This has been so great. I hope to talk and chat more. And I'm a listener now, so I'm learning, and I have 3 kids. What all of your listeners do is the most important thing, investing in our kids and our children. That's who's going to take care of us someday. We got to make them as durable, smart, strong, and healthy as possible.
Awesome. And we get the privilege of having an interview with your wife, talking all things perimenopause, hormone replacement therapy. And I'm so excited about that conversation. It feels great to just have the Kellys in our medical network of knowledge and expertise. So thank you again, Jake, and hopefully we talk again soon.
Thank you, Tracy.
We appreciate you tuning in to the Stay Fit Mom podcast. If you enjoyed today's episode, don't forget to subscribe and leave a review. Connect with us on social media and head to stayfitmom.com for more resources and tips. You've got this. See you next time.